Hello, and thank you for joining us here at Advise today. I'm very excited to be joined by David Bolden to be discussing one of everybody's favorite topics, evaluation and management codes. So thank you, everybody who's joining us on LinkedIn Live. I'm very excited to have you guys here and wish you all a very happy new year. As we kick off our webinars, we'd like to thank you guys for joining, but we would also love to get your insights and feedback on what are some of the topics that you would love to hear from Advise throughout the 2024 calendar year. So make sure to leave some comments in the posting and give us some feedback on what you would like to hear to make sure we're able to continue throughout the year to provide you quality webinars designed to really meet the needs of you, our viewership. So thank you again for joining. And David, thank you for joining me today.
Thank you.
As everyone knows, David Bolden is one of our subject matter expertise here at Advise on our certified professional coding, and he is joining us today to speak on a number of topics related to evaluation and management. As we all know, there's not a year that goes by in an SIU unit where you're not performing some form of evaluation and management audit. So we thought we'd kick off the year with a good refresher as everyone's kind of starting to kick off their 2024 audits, just to make sure that if you need to brush up on some of the standard protocols, procedures, guidelines, compliance requirements around the evaluation and management codes, that we're able to give you some high-level refresher information on today's session. So thank you for joining us. David, I'm going to kick it over to you if you don't mind giving a little bit of a background on yourself before we get things rolling.
Yes, thank you, Rachel. And hello, everybody in LinkedIn land. My name is David. I'm a coding and documentation auditor for Advise Health. I've been with Advise for almost, I want to say 4 years now, working in the E&M compliance space as well as in behavioral health compliance, reviewing documentation, coding, auditing. I also do a little bit of training as well. I really think that that's a key component to a lot of what we do as auditors is that training piece. So I do like to dive into that as well. So I've been in the healthcare space for over 15 years. So I do have experience working in both the payer and the provider side. So I think that gives me a kind of unique perspective on how documentation should look, as well as kind of some of those coding guidelines that we are going to go over today.
Thank you for joining us, David. I know we're going to kick things off a little bit on a little bit of a recap of some of the changes that have occurred kind of pre-2021, post-2021. Give a little bit of a refresher there before we start deep diving into some more current changes. So I'm going to go ahead and pass that over to you and get us kicked up here.
Thank you. Thank you. So, like Rachel said, really the 2024 changes, there's not many changes from the E&M standpoint. There are a lot of coding and kind of like guidelines that have changed in 2024, but from the E&M standpoint, it's really minimum, which is great for a coder and an auditor, really, if you're thinking about it. So, but we're going to kind of take a step back and talk about the pre-2021 E&M kind of rules and guidelines. So prior to 2021, everybody knows at that time, post 2021, there was the administrative burden kind of push where we were trying to make documentation a little easier for the providers. So pre 2021, the code levels were based on meeting or exceeding those three key components for the new patient, and then for established patients, you're looking at 2 out of the 3 key components being established. So, for time, it was determined by more than 50% of that encounter being dominated by counseling coordination of care. And everybody saw those little blurs within a documentation saying, I spent over 50% of the time, doing such and such. So that was a documentation requirement within the E&M code guidelines for pre-2021. Now, post-2021, once the Administrative Burden Act kind of like pushed through and we were trying to develop new ways for providers to do better on documentation as well as provide excellent care to patients, the determination for E&M coding was based off of an appropriately medically appropriate history and examination, and then an appropriate medical decision making. So I want to stop right there because for an appropriate history and or examination, what that means is that it still needs to be documented. So I think there was a little bit of confusion with the pre and post 2021 because a lot of the providers either just stopped documenting it altogether or they continued to document the three key components the way they would pre 2021. So the whole purpose of that was to relieve some of that administrative burden, right? So a really thing we want to push as auditors and as coders is that the provider should be modifying their documentation, and if they're using templates, modifying those templates in order to reflect those new post 2021 changes. Um, and so yeah, that's one of the kind of like high level things I kind of wanted to touch on. For time for post 2021, it also was determined by the total time spent on the date of the encounter. And we'll go a little bit more into that with the 2024 because that verbiage has changed some for 2024. But for the time portion of that post 2021, that was the determination for EM coding for time.
Yeah, I appreciate that quick rundown and refresher, David, as we're kind of getting more into current years. I think always good foundational knowledge to kind of build off of what are some of the practices we may have done in audits in the past, but now what are the new things that we really need to take into consideration as we're auditing time periods, most likely around 2023, 2024, 2022. What are some of the new items that have come up in regards to evaluation and management codes that we need to make sure we're factoring in when our audit look back period might be covering, different requirements throughout that EM period?
Yes, yes. And so, like we said before, 2024 really didn't have a whole bunch of new changes for E&M coding, which is great from the standpoint of documentation and the providers and auditors, right? That's every year, like you're saying, every year something comes up with AMA and CPT and CMS where they're trying to kind of navigate how to define certain things. And a lot of the times that disconnect was between AMA and CMS, where you had a definition for one thing from AMA and the CPT guidelines, but then you would go to the CMS guidelines and it would be worded slightly different. So then you would have to determine which one you want to go based off of who you're actually billing. So if you're billing Medicare patients, Medicaid patients, commercial patients. So it really became a struggle, right, for a lot of providers to kind of understand, what do I do? And in those instances, just from experience and background, I would always say take the most stringent, right, guideline possible, and then use that because you're never going to go wrong with the more stringent. But so for 2024, one of the bigger changes was the time component. And so even though it's not really significant as far as definition, it does align better with CMS guidelines. So now we're starting to see the AMA and CMS really kind of talking to each other and aligning in their definitions, which I think is a crucial thing. And it's huge within the healthcare industry right now, just based off of where we're heading, right? So, there haven't been any changes to the 99211, which is your post 2021, which is your office or outpatient evaluation and management that doesn't require the presence of the physician. So those are for your NPs, your PAs, or any of your advanced practice practitioners. Those ones, that particular code itself hasn't changed for 2024. So you would still be billing that and reporting that for anything that doesn't require the presence of a physician. So, lab work, just calling to check up on a patient and let them know what their lab results are, that kind of thing. But for anything outside of that, for your 99202 through 99205, which is your new patient E&M codes, and then your 99212 through your 99215, which is your established codes, some of the timing definitions has changed. And so I want to kind of go over with you just like what that table looks like and the comparison between 2023 and 2024.
Yeah, go ahead and share here a slide for David. You're going to see that, David?
Yeah, I see it.
Perfect.
Awesome.
So I just want to make sure I'm pivoting correctly there. Is this kind of what you're starting to reference there around some of these time changes?
Yes, yes. And so as you can see for 2023, the total time spent on the date of the encounter, the definition, it was given a time range. So your new patient E&Ms and your established patient E&Ms had a time range in order to kind of fit which code would be the one you reported based off of the time that's within the documentation. For 2024, however, what CPT has done and AMA and CPT has done is they've better aligned with other time codes that CMS has, and they have taken out that time range and given a minimum time. So it has to be, and the definition, as you can see, it says that it's on the date of encounter, but it must be met or exceeded. So for instance, the 99202, in 2023, you had the time range of 15 minutes to 29 minutes. However, in 2024, now 15 minutes has to be met or exceeded, right? So for the next code, you've got your 30 minutes to 34 minutes, and then for 30 minutes for 2024. So really the core essence of those codes hasn't changed. You're still going to be reporting them based off of the same amount of time if you really think about it and look at the table. However, the definition itself has changed, which aligns better with those CMS guidelines for other time codes. And I think that's really crucial in this standpoint because there are other codes that also are included when you're billing ENM codes, or you might be billing ENM codes, such as prolonged services. Those types of codes, they didn't align with each other. So AMA and CMS had different definitions. So this could be the beginning of a lot of definitions really changing within the AMA and CPT space to align better with CMS or vice versa, right? So I think that it really shows that connection, and it really shows the collaboration that's happening within the healthcare industry to make sure that we're not only providing the best care for the patients, but also reporting like we're supposed to. So I think that, from the standpoint of an auditor and a coder, it's really important and really crucial to be billing the correct code so they're getting proper reimbursement. A lot of the times we see in the news, people are getting a lot of overpayments, and providers being overpaid for services, a lot of recoupments happening because a lot of the systems themselves aren't catching these things within the system, or don't have the correct edits in place to catch those things within the system. So I think it's very important to have those providers educated up front, right? You have the education up front prior, instead of trying to chase after the money. I think that's very important in this standpoint.
So David, if you put yourself in the provider's shoes and you're seeing kind of the descriptions change here of must be met or exceeded, right?
Mhm.
At 15 minutes, understanding then they go from a 2 to a 3. There's right still that almost 14-minute gap right there,
Mhm.
right? So it does seem generally to be hinting at about the same type of language but stated differently. So if I'm a
Yes.
provider or an auditor approaching those medical records, should I be approaching my documentation or how I'm evaluating the documentation in that medical record differently based on this? Or is this more of a celebration of alignment across CMS and others really working to coordinate on definitions to just kind of pull out the ambiguity maybe a little bit in those descriptions in those
Mhm.
categories?
I do think it's a little bit of both. I'm glad you brought that up because I think from an audit and kind of provider standpoint, the same thing is in place. The documentation should still support what you're doing within that time frame. So if you are choosing to report those codes based off of time instead of medical decision making, it's really important to make sure that the documentation is supporting what is happening within that 15 to 29 minutes, or post 2024, 15 minutes to 29 minutes essentially still, right? So the documentation should still say what kind of counseling was done, what kind of coordination was done. Are you looking at lab reports? Are you doing like pre-checks before the member comes in to make sure to look at reports and look at other documents that other doctors and providers are doing with that member in other areas that might affect your treatment or your level of decision making, right? So I think that from a documentation standpoint, nothing's really changed, but from that standpoint, it's still important to remember that even though these definitions have better aligned with each other, from the AMA and CMS standpoint, it's still crucial for that documentation to be supportive, because otherwise we're going to run into the same issues. So regardless of whether or not you're putting in there, you spent 20 minutes, 25 minutes, 35 minutes doing something within the documentation. If there's nothing else within that note other saying that I spent 30 minutes with the patient, what did you do in that 30 minutes? Right. So it's still not supported as far as why you're supporting that 99213 or 99203 with that 30 minutes. So I do think it's crucial, from that standpoint, from a auditor and provider standpoint. Now, from the definition standpoint, like you were saying, I do think that it does show that they're trying to reduce some of that ambiguity, right, in the definitions, in the language, and then some of the confusion that everybody's experienced. Even as an auditor, I've experienced confusion. Go from I audit different states, so from a federal, from the state, from Medicaid, Medicare, and commercial. And so you go to someone's policy and you go to the exact same policy for a different provider within the same state, and it's completely different. Right. So
Yeah.
it's a lot of confusion. And I think that this is really, like I said, the step towards showing that we're trying to align better so we can potentially reduce some of that risk that we're seeing within the the healthcare space.
Okay. Yeah. Thank you for that clarification.
Yeah. Yeah. Sure. And so really, like I said, I just want to wrap up with that time piece of it. And so the um because the verbiage is better kind of aligning with CMS, I do think that this is probably one of the crucial times as far as kind of talking about telehealth services as well, because telehealth was a big thing, obviously, right after the pandemic, in the PHE ending in May of 2023. You know, Prior to that, CMS kind of just threw out these things for providers to do. And no one was really given any guidance as far as how to bill for telehealth services. No one really said, hey, this is what I need to do in order to make sure that I'm reporting correctly, or if the member or the provider is hesitant about meeting face to face, like this is what I need to report, this is what I need to do, this is the platform I need to use, HIPAA compliance, right? Or for our compliance people out there, we've got a compliance thing, kind of avenue in there as well. So, I do think that with that alignment, and with that clarification, we also see some changes happening in 2024 with regards to telehealth services. So, the final rule that Medicare put out for in November of 2023 talks about some of the flexibilities that they put in place prior to the pandemic. And then, so what they're going to be doing is they're going to be extending those through 2024. The funny thing is that CPT guidelines has now kind of given some more insight as far as what constitutes audio visual and audio only services. So that is something that's actually pretty unique, because prior to that, that wasn't really clearly defined, and it wasn't really given to the providers what classified as an audio video platform versus an audio only platform. Now, common sense, you're thinking audio only, telephone, right? So you call the patient, you say, hey, what's up? Right? And then
Yeah.
that's audio only. And you're not really looking at an audio only service to last hours long, right? So for the audio visual, there were other components in it as well, as far as making sure that the member had the right platform, make sure they could sign on, make sure that they were in a room that weren't around other people for HIPAA, kind of related purposes. As far as the exam is concerned, I think the biggest thing for the audio video during the pandemic was providers trying to understand how can they incorporate the member in their own care. So you're not there really you're not there to exam or to monitor the patient or give the exam. So how do you navigate, or how do you verbalize to the member, hey, do this, like count this, like, do you have this? Like, what's your, blood pressure? Do you feel this? Do you feel that? So I think that it really pushed a lot of providers during the pandemic in order to think outside the box and not just do the daily routine that they were normally doing prior to the pandemic. Um,
Are
and
there any
so
specific services, like if you're evaluating an E&M related claim and you're seeing that it is telehealth, and maybe it's audio only or audio and visual, are there certain criteria, I would assume, where some visits really require always to be a visual as well as the audio, and then certain services that are more focused and capable to just be covered through an audio visits? Can you speak to that a little bit in your experience and what you've been
Yes,
reviewing?
definitely, definitely. And so what I saw, especially with CMS, is that they had a list of telehealth approved codes, and so that list changed rapidly throughout the years, and a lot of different codes and services were added to that list because they realized that, hey, the pandemic is here and it's here to stay, so we need to make sure that we are still providing the same level of care to the members as we can. So I do feel like that list kind of grew and evolved over the years. But you're right, there were certain codes that were kind of excluded from that versus those codes that weren't. For instance, psychotherapy. A lot of my background is in behavioral health and psychotherapy. So, them being added, those particular code sets being added to the audio only, was a significant thing because prior to that, you had to be face to face. It was a face to face service. So, that audio only component to psychotherapy services really helped expand that particular service, but it also opened up a lot of risk for that particular service as well, because now you're having a phone call and you're not really seeing the patient, right? You're not really seeing them while they're talking, or kind of monitoring their mannerisms or seeing what they're doing as they're talking to you. So someone talking over the phone could sound perfectly fine, but if you see them as they're talking, right, you kind of notice certain small things as they're talking that maybe might cue you to ask follow-up questions, those kind of things that you would kind of expect from a therapist within a psychotherapy session. So, it really did open up that world of risk, but it did expand. So CMS did create that list to make sure that we were providing the services still.
Yeah, thank you for that clarification.
Yep, yep. And so with that too, kind of going further in depth with that, those modifiers too, the CMS created modifiers for telehealth services. So the 95 modifier was one for the synchronous telemedicine services for audiovisual services. They also created now the 93 modifier, which is specifically for audio only services. And so that's kind of something new within 2024 that we're going to be seeing a lot more of, because providers are going to be expected to bill the 93 modifier versus the 95 modifier, depending on whether or not it's audio video or if it's just audio only. So I think that's going to be a change that we're going to be seeing in the reporting space, from an audit standpoint. Um, Also, as of August of last year, telehealth platforms were better defined as far as what a HIPAA compliant platform was. So I know, during the pandemic, you saw everybody getting on TikTok and using all. So they were like, "Oh, we'll use anything we want to in order to kind of meet with the patient, because we're trying to meet them where they are, and we'll use anything." So that has gone, and they're very clear as far as what classifies a HIPAA compliant platform, and this is through the Office of Civil Rights. So the OCR, kind of created this list. So FaceTime, Skype, Google Hangout, TikTok, Zoom, not compliant anymore. Those are platforms that are no longer able to be used by a provider in order to provide services. As an auditor, I've seen a lot of providers use DoxyMe, WebEx, GoTo, Teams. There's even some enhanced Skype platforms that they have out there where the providers can meet with the members, and actually provide those audiovisual services, and those would be considered those HIPAA compliant ones. So,
Are you typically, when you're reviewing medical records, are you seeing references of what platforms that they're leveraging when reviewing a specific service? And how should one think about that when going through an auditing?
That's funny. So good. I'm glad you brought that up because that is one of the documentation pain points that I see a lot of the times is that the reference to what platform is not in the documentation. And so that again is going to be a crucial thing for providers to make sure they do is to add that information within the note. And it can be templated. I wish 50-50 on templates as an
Mhm.
auditor, right? You know, they have their good things and they also open up some risks. However, if it is easier for the provider to use a template in order to say, I use Doxy, me, in order to provide this audio visual service, or, they were given the attestation. The member was given that attestation prior to the service saying, we're going to be using this particular platform in order to provide services. So that kind of level of detail should be in the documentation. And so I'm glad you brought that up because normally from I don't see that. And that is something that I will point out as an auditor and as, just a training opportunity saying, hey, you might want to make sure that you're adding this in there because depending on who is looking at your record, they may come back and say, you're not using a HIPAA compliant platform if it's not clearly documented.
Yep. No, that's a great call. Thank you.
Mhm. Um, So with the OCR kind of making those definitions as far as what's a HIPAA compliant platform or not, all of the audio and video telehealth office visits were extended through the end of 2024 with the Consolidated Appropriations Act, and then the Medicare final rule with some restrictions. So that is a good thing. Obviously, telehealth is pretty much here to stay. I think that the pandemic really opened up the eyes of a lot of healthcare providers as well as payers as far as what can be done, you know, over telehealth versus face to face. And so I think something to remember in 2024 for providers, though, is the documentation is going to become crucial. And I keep hitting that, right? Documentation, 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 because the documentation has to support why that member is getting telehealth services versus face to face. The pandemic, the PHE ended in May of 2023. So, the members may prefer to do their services over the phone or audio video. However, is that the best for the patient? So the providers got to really be vigilant with regards to how they are documenting the reasons for these telehealth services, because even though the telehealth audio video guidelines and audio only guidelines are extended until the end of the year, I feel like CMS is really going to be cracking down on how many telehealth services we're going to be seeing. We saw 95% of services being done in telehealth in previous years. And so I feel like dwindling down that number is going to be something that CMS is going to be looking at doing because we want to make sure that we're providing those services appropriately to the members. And sometimes audio, services are not appropriate. So
That makes sense. Yeah, and I think, to the stat that you're referencing, right, that was probably key lockdown periods, right? Not
yeah.
a reality that we all continue to live
Oh,
in our day to
definitely,
day,
definitely,
right? So it makes
definitely.
sense from that focus. But I think one of the things that telehealth really has also done is in rural areas, right? Access to care,
Mhm.
vast improvement there. So to
Yes.
your point, I think there is a little give and take and like finding what is that right balance for telehealth as we continue to kind of come out of that pandemic period and the public health emergency, but ensuring still appropriate access to care in different regional areas. I think it's going to be a really interesting challenge from a CMS
Definitely,
and
definitely.
regulatory basis. It'll be interesting to see how that continues to evolve.
Yeah. And then I think still from an audit standpoint too, we still see providers who are constantly billing for, all their services are telehealth, right? And we're like, well, why are all your services telehealth still? You're downtown, Seattle.
Mhm.
Like, why are you
Mhm.
not able to see patients that are in downtown Seattle if you're in downtown Seattle? So I think it's going to be something that's interesting. I'm really excited to see that kind of change and that shift in um, uh, kind of lens from CMS in 2024. Um, Now, another thing that changed in 2024, starting January 1st, was the use of the place of service modifier 2. So, place of service modifier 2 was used when, for telehealth services, it was supposed to be attached as a modifier to kind of represent that the member was receiving telehealth services. In 2024, CMS created, or AMA and CPT and CMS kind of collaborated in creating POS 10, which is to be used for when the patient is in their home at the time of telehealth. So now place of service 2 is going to be used for when the member or the patient is outside of their home. They're not actually in their house. So that's going to be a huge change because the documentation actually should be saying the location of service. So if that documentation is saying that the member is in their house, they should be using place of service 10, which historically you would have seen place of service 2. So I think even though prior to 2024, those things weren't attached to a reimbursement rate, it does look like CMS tied that to a facility and non-facility rate. So for those Medicare patients, if you're not billing the right modifier for place of service, it could potentially result in an overpayment, which again will cause an audit. And so it's just this unnecessary things that will be happening in 2024 if these providers aren't going through and educating themselves on which codes have changed for 2024. Yeah.
Place of service, I think that was another one always evolving a little
Oh,
bit of
yes.
understanding throughout the pandemic. So glad to hear that continues to evolve and hopefully provide some additional clarification for both from the provider side and then those who are reviewing the medical records on the auditing side. So I think any additional transparency in that regard is always going to be helpful.
Yes. And then just as a reminder too, like a lot of the changes that happened in 2024 are at that CMS level, so Medicare patients. So for Medicaid and commercial, it's really important for providers to follow those particular payer guidelines and then also educate themselves on whichever payers they're billing. So like I said previously, each one of those payers have different guidelines, have different ways of kind of interpreting the overall CMS, guidance. So I do think that it's important too to just point that out as far as these particular 2024 changes might be something that Medicare level, which, like I said before, maybe you want to kind of push your guidelines, or providers want to push their guidelines to be in the more stringent area versus the more lax area. So if I were a provider, I would probably follow the Medicare guidelines just because that to me would be, kind of like the overall arching, guideline to follow, or at least close to it as possible. But I just wanted to point that out that it's still important to check your payer guidelines as well, not necessarily just follow CMS guidelines, still check your payer guidelines.
Sure. Thanks for that.
So post pandemic as well, audio only codes are going to be only for established patients. So prior to, they were for new members as well. Excuse me. So that is something also that's going to be very important. I don't think it's from an audit standpoint. I didn't necessarily see a lot of providers billing for those E&M codes audio only for new members. However, for those providers who aren't aware, that is something that did change after the PHE ended in May. So it's only for established patients, and that should be something that should be kind of told across the providers within their network. At the end of 2024, those particular audio-only codes will be deleted, and new telehealth codes will be established at that time. So they haven't told which codes those will be. However, I do think that that's important to point out too, because we don't want providers to become too dependent on billing those particular codes throughout 2024, because they're just going to be deleted in 2025. So like I said before, CMS is really trying to change the way they're doing things to better align with AMA and CPT. And I do think that some of that is going to be kind of the reduce, kind of seeing that reduced use of the telehealth codes versus the face-to-face and things that we can actually do face-to-face. So for AMA and CPT, they actually created appendixes, and I think you had brought this up before, Rachel, as far as a list of services that would require particular modifiers in the telehealth space. So AMA and CPT actually did create a list. And so they have a list of audio only services that require the 95 modifier, and it's in the Appendix P of the CPT guideline book. And then the audio only services with the 93 modifier, they created an Appendix T. And so that's really important, especially for providers to know too, because that's that coding piece of it and making sure that they're getting reimbursed properly. So, it's important. And I'm not sure from an audit standpoint, I'm not really sure if I know of a particular guideline that states that you have to have a coder. However, I always like to say that it's very important to have one and is probably beneficial for a person to have a coder instead of doing their own billing. And the only reason why is because, as you can see, there's lots of kind of different nuances and changes that are happening. And like you said before, a lot of changes happened from 2021, 2022, 2023, 2024. So a coder would kind of get these updates and be able to bill appropriately, and kind of understand and interpret those and help the provider navigate that documentation piece. So, I do think that that's something too that we want to keep in mind for 2024, is that if you don't have a coder or somebody who's kind of certified in looking at codes and billing, that might be something you want to look at in 2024.
Okay. Yeah, thank you for sharing that reference material. Definitely helpful.
Mm-hmm. And so lastly, I kind of want to talk about the telehealth guidelines for crossing the state line. So during the pandemic, we saw a lot of E&M codes and a lot of providers billing E&M codes across state lines. So providers from different states kind of billing without that established relationship with the member. And so I do think that in 2024, we're seeing that this AMA and CPT and CMS are really cracking down on that. And what they're actually installing and kind of, establishing is that the provider is only allowed to be licensed in the state where they're located at the time they're providing the treatment. So, for example, if a physician is licensed in, let's say, Illinois, and then the member resides in Illinois, but is on Florida for vacation, that provider has to be licensed in Florida in order to provide that telehealth services. So they have to be licensed in both Illinois and Florida in order to provide those services. So I do think that even though that's not necessarily a huge change, I feel like that, it's more common sense than anything. I feel like, it's something that providers need to be aware of, because that also will influence how E&M codes and E&M visits are going to be reimbursed, especially with these telehealth services.
No, it's a key call out, and I think to your point, David, as telehealth has grown and expanded, so has access to care when you're getting on close to state borders, right? I think that's where you typically can see that grow and expand a little bit more, and something just really important to look out to, both from a provider perspective, make sure you are taking all the necessary steps, right, to make sure that you're getting the designations you need, but also from an auditing perspective, another key criteria, right, to make sure that they're keeping an eye out for as we're thinking through telehealth when we have potential providers where services are being provided across state lines, some additional documentation that may want to be requested as part of the initial medical record and documentation requests.
Yep. Exactly. And to your point, I do like how you kind of brought up the fact of far as access to care. Excuse me. The final rule that Medicare put out actually has a lot of other kind of updates that they're going to be doing in 2024 for access to care for behavioral health space. That's another space that is kind of, one of those, huge things that happened in 2023, especially during the pandemic, right? We saw a lot of people getting more mental health services, reaching out for, more help, and kind of becoming more aware of the fact that they needed, to have these types of services provided. So in the behavioral space, CMS and Medicare and AMA and CPT, they're all kind of aligning and understanding that, behavioral health is something that is crucial within everyone's life. And so I do think that we're going to be seeing a lot of access to care kind of updates with regards to behavioral health. So I do like how you brought that up. That was a very good point as far as those access to care and crossing lines, and especially all this is connected, right? Telehealth and behavioral health and, all these things, we're seeing these things that are happening. And I think it's very important that providers are seeing the bigger picture, and they're making those steps and taking those steps in order to adjust their business practices accordingly.
Agreed.
Yeah.
David, thank you as always for taking time to educate all of us on some of the upcoming changes or current changes across CPT, AMA, and CMS and billing guidelines. So thank you for taking the time today. Any additional items you wanted to know before I move forward and wrapping up here?
No, I really appreciate the time. I thank you so much for inviting me out. And like I said, everything is always changing. So these E&M codes and changes and each year something is different. And I think, like, I'm going to drive it home again, it's documentation is key. Documentation, documentation, documentation. As far as an auditor standpoint, we always hear when we start off, if it's not documented, it didn't happen, right? That's the saying. So I think that even though that's a very basic kind of statement, it does hold true still, even after all these years, is that, we want to make sure that providers are documenting what they're doing. We're not, and it's from an audit standpoint, we never want to say that a provider isn't doing the service, but if the service isn't documented, we're not there. We don't know what's happening during that service. We don't know what interaction happened between the member. So that's why it's very, very important for the provider to understand whatever you document in that record is really that caption of what happened during the visit. And so if we don't have a full picture of what happened during the visit, how can we accurately say this is what you should have been paid versus something that might be a little lower that you did meet, right? So, yeah, documentation. I can't say it enough.
Okay.
Can't say it enough. Documentation.
No matter what services we're referencing, the answer is always going to come back to documentation. So, David, thank you so much for joining today. And everyone viewing, thank you so much for joining us on our webinar here today with Advise. As always, we encourage you, if you'd like to sign up for our newsletter, please send us an email at hello@Advise Health. And we also encourage you to check out some of our previous postings on LinkedIn, and please go out and check out our YouTube channel, where you can find some more of our webinar materials and content around the OIG roundtable and other topics. So thank you so much for joining us today. David, it is always a pleasure speaking with you and looking forward to it. And thank you everyone for joining us today. Thank you so much. Bye.